This is Salma Schimmel at the AACR annual meeting for the Group Room, and this is the American Association for Cancer Research. We're in Chicago, and we're now joined by our good Group Room friend, Dr. Weitzel, Professor of Oncology and Population Sciences, Chief of the Division of Clinical Cancer Genetics in the Department of Population Sciences at the City of Hope Comprehensive Cancer Center in Duarte, California.
Good morning, Selma.
Hi,
Pleasure
Dr.
to be
Weitzel.
here.
How are you?
Good.
So I'm glad we have time to talk to you. You have time to talk to us because more and more in our discussions here on a research level, we're speaking about the BRCA mutations, and typically people associate them with the Ashkenazi Jewish population, but you've done some very important research in the Latina patient population, and I'd love to explore that with you, and then some of the issues of disparity as it impacts cancer genetics.
I'd be delighted to talk about that. We've been working in the underserved populations for almost a decade now, because for a long time, while gene for BRCA1 and 2 were both cloned in the early 1990s, commercial testing became available in 1996. It's been 16 years, but it's only been in the last year that public health services even provided coverage from a Medicaid perspective. So we've been taking care of typically underserved Latinas for a long time, and we've learned some lessons along the way about mutations in the BRCA genes. Interestingly, every population in the world has BRCA mutations that are responsible for breast cancer when it looks like it should be hereditary. People getting it at an early age, breast and ovarian in the same family. If it looks like that, it's BRCA. I don't care what part of the world they're from. And so it turns out that there's some very interesting patterns in that population. And we've been discovering that, for example, you mentioned Ashkenazi Jewish ancestry. Well, it's long been known that 3 mutations account for 90% plus of the cases in that population. And because of that, there's a slightly higher risk for breast cancer, although it's not materially much larger. But in the Latinos, one of the most common mutations we found is actually a Jewish mutation. We found the 185 del AG mutation, which is a specific mutation, and we saw it in 4 families, and they're multi-generational Catholics, so we thought, what's with that? We compared it to our Jewish patients from Los Angeles, where we had done genotyping, and we showed that they shared the same chromosome. They have common ancestry. And if you look back in history, and I'm not the first to come up with this, although in 2005 we were some of the first to publish that this was actually a connection. But the Spanish Inquisition, there were thousands and thousands of conversos that one time they all moved to Portugal. Even Portuguese was an intermixing term for Sephardic Jews or for conversos.
Ladino?
Ladino's another term for that. Yeah, there are a number of terms that have come out. Hispanos is another one that's come out. And basically there was a migration. There probably were some on Columbus's boat. And so this became embedded in the population, as it were. Even Catholicism, as it's practiced in Mexico, has some Old Testament characteristics that suggest the integration of Jewish rituals. So it's interesting, but it's more than interesting. It just serves to amplify our connectedness to the world. You know, there is no separating. We are truly a global community. And right now we know that that particular mutation, from work we've done in almost 1,000 cases, is about 10% of all the true positive mutations in that population. And so it's actually a clinically relevant proportion of that population.
I remember reading somewhere that, yes, on Columbus's journey here, that there were many Jews, and in fact, the first person off the boat, people were afraid to get off the boat. It was, they sent a Jew off the boat, so it was a Jew.
To test the water. No sharks.
I also have read that regarding the Ashkenazi community going back to Eastern Europe, that the pogroms, so people were forced to intermarry and very close relations with relations. Is that factual?
I don't think there's any question that it's factual. And from the medical perspective or the geneticist perspective, we look at what's the eventual effect on the population. And the eventual effect was that it meant there was a restricted background of mutations in that population, that it was overrepresented. Any population that's been geographically or culturally isolated has founder mutations. A good example is Iceland. I used to say nobody's trying to get into Iceland, but then I've read that they have a pretty good quality of life. But there's a single mutation in BRCA2 that's a founder mutation there. Counts for most of the disease. So it isn't being Jewish, it isn't any of those things. It's any population that's been culturally or geographically isolated.
Right, which is what I meant about it being factual, that it was because they were compressed in a and maintained in a small pocket that it ultimately impacted the genetic.
And there's a lot of cultures that stay within their tribe, so to speak. And so there are definite examples of this around the world. An example that we've discovered in Mexico, which is very interesting, is that while this Jewish mutation was quite prevalent, we know when that happened, around the time of the Spanish Inquisition. So we know about how old some of those mutations are. So there's some speculation that 185 Del-AG goes back to the second diaspora, the destruction of the Second Temple in Israel, so almost 2,000 years old. We found a mutation that's a large rearrangement, and there's something important about large rearrangements in these genes, and that is the conventional test sequencing doesn't pick it up. It has to have a special add-on test. And that means that a lot of docs are missing the boat when they order just the sequencing test. Nonetheless, this large arrangement mutation we found in the Mexican population, or our Mexican-American population, turned out to be responsible for 10% of all the positives that we had. We saw it multiple times. We've seen it almost 20 times now. We compared, there are ways to look at flags along the chromosome and actually estimate how old do you think the mutation is. And we've estimated that it's about 1,500 years old. We've never seen it outside of the individuals who have Mexican ancestry, and we've also done what we call ancestry informative markers. There's ways that you and I could determine just what our background is from a world geographic perspective, and it turns out to have more Amerindian ancestry. So if you put this together with my new love, which is world history and anthropology, it turns out that in about 1,500 years ago in Puebla, near Mexico City, the Mayans and the Toltecs were merging. And so we actually think that this is the first Mexican founder mutation. It's clinically relevant, and is clinically relevant in the sense that it's missed. In fact, we did a study and showed that among 21 times we found a large arrangement mutation, over half the times they wouldn't have met the insurance or genetic testing vendors' criteria for testing, which would have been a problem. They would have been missed.
How do you explain your colleague, Dr. Fumi Olopade from University of Chicago's work in Africa?
Sure. So Fumi Olopade at Chicago has long been a story. In fact, she's the Dean of Global Affairs, and so really has had a worldview for a long time, and her own origins are in Nigeria. So she has been working in African American populations, again like us, addressing disparities, thinking about the African population here in Chicago, but really across the country. And over time, we've seen a few mutations that were repeating in the African American population. And she's essentially traced some of the roots back to Nigeria and has done work there. And as you know, triple negative breast cancer is talked about a lot. There's a higher prevalence in African Americans. It's not all accounted for by genetics, but there's a surprising prevalence of BRCA mutations in the Nigerian population. And this brings, again, one of the books that I've been interested in lately is Guns, Germs, and Steel. And this is about the influences of essentially colonial conquests and world events on prevalence of things. And one of the things, of course, that's talked about is the slave trade. And so the African slave trade affects not just the African American population, but the Bahamian, all of the islanders. And so it turns out that we see founder mutations that have African roots that are very prevalent in some of the islands. And also it affected Mexico, because South America and Mexico were, of course, part of that. And so in Mexican ancestry, we talk about mestizo, which is a mix of Amerindian, African, and European. And so it really is a world or global perspective.
It's fascinating because when you mentioned that your new love is anthropology, how enormous the connection is between genetics and genomics. And when you think about, yes, the historical anthropologic connection,
it also helps you think about us as a society and how we treat people, but that's another entire story, and the importance of equity. And to me, that's part of our push to provide access, because clearly women have benefited from knowledge about BRCA mutations and how they can literally, I tell women now when I talk to their daughters, I tell them, you don't have to follow the same path and have your mother's experiences. We can now, with what we have know already, we can change that story.
Yes.
And so with that being, you know, a passion of what we really want to do at the end of the day, I mean, I'm fascinated by the world history and by the genetics, but it's really only one end game, and that's to prevent cancer.
Right, and you know what, my story is known to everyone, but I am the, you know, the classic textbook case of the BRCA family, grandmother, mother, me. I'm the third generation, as is my sister. Her daughters tested all negative.
Isn't that wonderful?
So, yeah, and so it ends, I have no children, and so it ends with both my sister and myself. But after this legacy, and I don't know about my great-grandmother, so the breast ovarian syndrome has
or
been
your
passed on.
great-grandfather.
Exactly,
We can't
exactly.
forget
It's
that
50-50.
half of the time
Exactly.
it's the man who's transmitting the trait.
And when we got tested, we also tested my father.
Oh, you did?
Oh, yes, and he was negative, and it was very clear where it came from, especially with the mortality.
We don't make many
in my
assumptions.
family.
We want to always be sure.
Right, no, but we tested purposely because both our parents could have been positive.
That's right, and,
So-
and 1 in 40 individuals may have one of the 3.
And I think you've raised a very important point, because men as well as women need this testing, and now that we understand also about the cancers beyond breast and ovarian.
That's
and
right.
I understand there to be colorectal, prostate, pancreatic.
I think the clinically relevant ones are going to be prostate and pancreatic. The colorectal is probably not associated. At one point we thought it is, but it fades in and out of connection. But prostate cancer, one of the recent findings is that clinically relevant prostate cancer is much more prevalent in BRCA2 carriers in particular. And that's important because in a time when we're debating whether to do PSAs and whether to do screening at all in men, the reality is our current guideline for the National Comprehensive Cancer Network is to start at 40 and to screen these men because of the clinically relevant prostate cancer being a problem.
And with the challenges with pancreatic cancer, this is vital information. Would it be BRCA2 in pancreas?
BRCA2, again, the more prevalent association. We found some other interesting genetic connections to pancreatic in the recent past, but yes, it's pancreatic, and that's an area where we don't have as well-established screening studies or screening tools. Endoscopic ultrasound is one of the things we're using now, and it's an expensive tool. It's a big learning curve, a lot of equipment expense, so we should at least select well who we're going to do this for. So I think it becomes a tool. It's really an area that needs a lot of work.
I could go on talking to you all day, Dr. Weitzel. Thank you very, very much, and I just love that you're also integrating your studies with anthropology. It just makes so much sense.
Well, it's a global issue, and I think we do need to pay attention to global health. I'm glad to see that the NIH and other bodies are starting to do it, but there's just not enough focus, I think, on that. Whole populations still don't have access to what I would consider life-saving care.
Dr. Jeffrey Weitzel, Professor of Oncology and Population Sciences, Chief of the Division of Clinical Cancer Genetics in the Department of Population Sciences at the City of Hope Comprehensive Cancer Center in Duarte, California.
Thank you so much.
Pleasure.